Okay, picture this. It is 3 o'clock in the morning on the medical ward.
Oh, the classic witching hour for decompensation.
Exactly. The lights in the hallway are dim. The nurse's station is, finally quiet. But then your pager just goes off.
And your heart instantly drops.
Right. So you walk into room 412, and the patient you admitted maybe like 6 hours ago is sitting bolt upright. They're completely diaphragmatic, just gasping for air.
That is a terrifying room to walk into.
It really is. And you look at the monitor, and the oxygen saturation is reading 84%, and it's dropping.
So you need data immediately.
Right. So you call for a portable chest x-ray, but the radiology tech is stuck down in the ER with some massive trauma. You ask for an arterial blood gas, but respiratory therapy is completely backed up.
Which happens, frankly, all the time.
Yeah. So you are standing there at the bedside of this rapidly decompensating human being, and all that high-resolution diagnostic machinery you normally rely on, it is simply not available.
You are stripped down to the absolute basics.
Exactly. You just have your hands, your eyes, your ears, and your stethoscope.
And I'll tell you, that is the ultimate crucible of clinical medicine. I mean, we train in this era where you can just, order a high-resolution CT scan of the thorax with a couple of keystrokes.
Which is amazing, but
it creates this profound, almost dangerous reliance on imaging. It becomes a technological crutch for a lot of junior clinicians.
yeah, you forget how to actually look at the patient.
Precisely. Because when you are standing in that room at 3 a.m. trying to navigate these really murky diagnostic waters of acute respiratory failure, the physical exam isn't just some historical parlor trick.
Right.
It is a high-fidelity, immediate triage tool. I mean, it dictates right then and there whether you push furosemide or administer a bronchodilator or literally prepare for emergent intubation.
Which is exactly why we built this specific deep dive today. And just to be clear, this is not for the layperson.
No, absolutely not.
This is custom tailored for you, the medical resident, the intern, the clinician who is operating on the front lines. Our mission today is to take those massive, hours-long clinical lectures, the bedside rounds, the OSCE rubrics, and synthesize all of that raw data into a definitive, exhaustive masterclass on the respiratory physical exam.
I love that. We aren't just going to review a checklist of maneuvers.
No, we are tearing them down to the studs.
Yeah.
We're going to look at the acoustic physics, the underlying pathophysiology, and the really rigid clinical reasoning you need to translate, like a Sybil tap on the chest, into actual actionable diagnostic gold.
Because the goal here is to elevate your exam from just rote memorization into a totally dynamic, hypothesis-driven investigation.
Right. Every time you touch the patient, you should be asking a question.
Exactly. A specific physiological question. And your hands or your stethoscope should be retrieving the precise answer. But to do that effectively, you have to have an uncompromising mastery of thoracic anatomy.
Because you can't find the pathology if you don't know the geography.
You have to know the map. You cannot localize anything if you don't know the underlying coordinates.
So let's pull up that map. When we look at the thorax, we are essentially trying to visualize this three-dimensional moving puzzle that's locked inside a rigid two-dimensional bony cage.
It's a great way to picture it.
And to navigate that cage, we have to establish our primary anchor points. So on the anterior chest, pretty much everything hinges on the sternal angle or the angle of Louis.
Yes, the absolute center of gravity for the exam.
Right. And to find it, you literally just drop your finger into the suprasternal notch at the base of the neck and slide down about 5 centimeters. You'll hit this very distinct transverse bony ridge where the manubrium meets the sternal body.
And I want to drill down into why that specific ridge is so critical. It's an anatomical goldmine because of what lies immediately deep to it.
Right. It's not just a bump on the bone.
No, not at all. Laterally, that ridge articulates directly with the second costal cartilages. So if you just slide your fingers off the angle to left or right, you are sitting squarely on the second rib.
Which means the space immediately below that is the second intercostal space.
Exactly. It's your 0 point for counting ribs downward. But internally, it's even more fascinating. If you draw a horizontal transverse plane starting at that angle of Louis, straight back through the chest to the T4-T5 intervertebral disc, you hit this phenomenal concentration of critical structures.
Right. That's the plane that marks the exact bifurcation of the trachea.
Yes. Into the right and left main stem bronchi. It also marks the superior border of the pericardium.
And isn't that where the aortic arch starts and ends?
It is, and it marks the bifurcation of the pulmonary trunk, too. Knowing that the trachea splits exactly at that level dictates where you place your stethoscope later to assess central versus peripheral airway sounds.
It really is the fundamental crossroad. So from there, you map the anterior chest by walking your fingers down the interspaces.
Yeah.
But I know there's a really common mechanical error that residents make here.
Oh, I see it constantly. They try to count the interspaces vertically, directly adjacent to the sternal border.
Right, just going straight down the middle. Why is that a problem?
Because the lower costal cartilages completely crowd together as they sweep up to articulate with the sternum. If you try to count straight down that peristernal line, your fingers will inevitably slip over a cartilaginous fusion.
Oh, so you just lose your place entirely.
You do. You'll misidentify the fifth intercostal space as the fourth, which completely throws off your physical mapping of, say, the heart border or the liver edge.
So how do you avoid that?
You have to walk your fingers obliquely, diagonally downward and laterally away from the sternum, just naturally following the curve of the ribs.
Okay, that makes total sense. Now, if we move to the posterior thorax, the back of the patient, our anchor points have to change, right?
They do, because the scapulae cover a massive portion of the upper lung fields, so we rely on the vertebral column instead.
Right, so you ask the patient to actively flex their neck, bringing their chin to their chest.
And the most prominent spinous process that protrudes right at the base of the neck, that's C7.
And if there are two bumps that stick out?
Then they are C7 and T1. You can use that to confidently count downward, or you can approach from the bottom up.
By palpating the free-floating 12th rib, right?
Exactly. Find that 12th rib, identify the T12 spinous process, and work your way up.
There is also the inferior angle of the scapula. When a patient is just sitting normally with their arms at their sides, that inferior tip consistently rests right at the level of the 7th rib, or the 7th intercostal space.
Yes, it acts as this super rapid visual and tactile landmark when you are percussing the posterior bases.
Okay, so we have the bony cage mapped. Let's project the actual lungs into this cage, because the lungs do not sit flat inside there.
Not at all. The 3D visualization is critical here. The apices actually project upwards, rising roughly 2 to 4 centimeters above the medial third of the clavicles.
Wait, above the collarbone?
Yes. They stick out of the top of the cage, essentially. And that superior projection is why apical lung tumors, like Pancoast tumors, can physically compress the lower trunk of the brachial plexus.
Oh, wow. Or the cervical sympathetic chain, right?
Right.
Which gives you Horner syndrome.
Exactly. The lung is not entirely contained by the ribs. Anteriorly, the inferior border of the lung crosses the 6th rib at the midclavicular line and then drops to the 8th rib at the mid-axillary line.
And posteriorly.
The resting lower border sits right around the T10 spinous process. But remember, the lungs are highly dynamic.
Because they inflate.
Right. Upon maximal inspiration, the diaphragm contracts and flattens out, and that posterior lung border descends vertically by 3 to 5 centimeters, dropping all the way down to the level of T12.
Okay, so that maps the borders. But this brings us to a massive clinical trap. I really want to talk about the right middle lobe.
Oh, the sneaky right middle lobe.
Right, because I've seen residents get absolutely burned by this during morning report. They examine a patient, declare the lung feels totally clear, and then the attending pulls up the chest x-ray, and there's a huge, dense consolidation in the right middle lobe.
It happens all the time.
How does that happen so frequently?
Well, it happens because of a fundamental misunderstanding of the oblique and horizontal fissures. So the right lung has 3 lobes, right?
Right.
The oblique fissure separates the lower lobe from the middle and upper lobes. Posteriorly, this oblique fissure starts incredibly high up on the back, near the T3 spinous process.
That is really high.
It is, and it travels aggressively downward and forward, wrapping around to end at the 6th rib at the midclavicular line. Because of that really steep diagonal plane, the right lower lobe occupies almost the entire posterior aspect of the right thoracic cavity.
Okay, so what about the right middle lobe? Where does it go?
The right middle lobe is wedged completely anteriorly. It sits between the horizontal fissure, which runs along the 4th rib, and the oblique fissure below it.
So it doesn't touch the back of the chest at all?
The right middle lobe does not project to the posterior chest wall whatsoever. Its acoustic footprint is purely anterior, sitting beneath the 4th intercostal space and wrapping around laterally into the right axilla.
Wow, so if a resident is in a rush, they just have the patient lean forward, and they only auscultate the back.
They are completely missing it. They listen to the left posterior fields, then the right posterior fields, hear clear vesicular breath sounds, and they just move on.
But they're only listening to the upper and lower lobes.
Exactly. A patient could have a severe purulent lobar pneumonia expanding entirely within that right middle lobe, and the posterior lung sounds will remain totally pristine.
That is terrifying.
To assess that middle lobe, you must deliberately auscultate the anterior chest wall. And you have to actively place the bell of your stethoscope high up into the right mid-axillary line. If you ignore the axilla, you're guaranteed to miss pathology.
It's totally a spatial awareness issue. You really have to actively hunt for that middle lobe.
You do.
Okay, so we have the anatomy down. But before you ever lay a hand on that chest or place your stethoscope in the axilla, you are actually gathering critical data from the doorway.
Absolutely. The exam begins before you even say hello.
Let's look at the Visual Gestalt, Section 2, the general inspection. This is where the most acute triage decisions are made, honestly.
Without a doubt.
And one of the most fascinating metrics of severity is the patient's speech pattern. Because you can have a patient subjectively report that they feel like they're suffocating, yet they describe this feeling to you in like a continuous 5-minute monologue.
Right, and the physiological reality of speech provides a very objective measure of their actual ventilatory capacity.
How so?
Well, normal phonation requires a sustained, controlled exhalation. To speak in long, flowing paragraphs, the patient must have a sufficient functional residual capacity, and their airways have to be patent enough to control that very slow release of air across the vocal cords.
Okay, so if they're talking continuously.
If a patient is speaking in full, uninterrupted sentences, they might be experiencing intense subjective dyspnea, sure, but they are not in objective, immediate extremis.
Conversely, true respiratory distress forcefully strips away that luxury of phonation.
It really does. The physiological drive to acquire oxygen and blow off carbon dioxide heavily overrides the secondary function of speech.
Right. Breathing comes first.
Always. A patient in legitimate, severe respiratory failure will only be able to communicate in highly fragmented 1- or 2-word bursts. They physically have to halt phonation so they can initiate the next rapid inspiratory cycle.
So documenting the exact phrasing like patient speaking in full sentences versus patient speaking in 2-word bursts is actually a vital, universally understood metric of clinical stability.
It is essential documentation.
Alongside speech, we look directly at the mechanics of the chest wall. During normal, quiet, tidal breathing, the work of breathing is remarkably passive, right?
Yes. The diaphragm contracts, creating negative intrathoracic pressure to draw air in. And then the diaphragm simply relaxes. The natural elastic recoil of the pulmonary interstitium and the rib cage just handles the exhalation.
It snaps back.
Exactly. But when airway resistance spikes or lung compliance plummets, that passive system completely fails.
And the patient is forced to recruit accessory muscles to physically overcome that resistance.
Right. For inspiration, the primary accessory muscles are the sternocleidomastoids and the scalens in the neck. If you looked at the patient, you will observe visible, forceful contractions of these muscles.
Like they are literally attempting to yank the clavicles and the first rib superiorly to expand the thoracic volume.
That's exactly what they're doing. And you'll also see intercostal retractions.
Right, where the negative pressure they are generating is so extreme that it sucks the skin and muscle inward between the ribs with every single breath.
It looks awful. And then exhalation, which, like we said, should be entirely passive, becomes this violent, active struggle.
Especially in severe obstructive states, right, like COPD or status asthmaticus.
Exactly. In those states, air is trapped in the alveoli. The elastic recoil is either destroyed or it's just insufficient to push the air out against the narrowed bronchioles.
So what does the body do?
The patient recruits their abdominal musculature. They forcefully contract the rectus abdominis to push the abdominal viscera upward, physically slamming it into the diaphragm to manually force the trapped air out of the chest.
Wow. But that massive recruitment of skeletal muscle has to drastically increase the patient's metabolic demand.
It causes oxygen consumption to skyrocket, which creates a vicious cycle that rapidly leads to respiratory muscle fatigue and ultimately ventilatory arrest.
To optimize this desperate mechanical struggle, patients will instinctually adopt specific postures. The most classic one we see is the tripod position.
Yes, sitting on the edge of the bed, leaning heavily forward.
Right, with both arms rigidly locked and braced on their knees at the bedside table. But why does fixing the arms actually help the lungs?
It is a brilliant biomechanical adaptation. So the accessory muscles of the neck and upper chest, like the pectoralis major and minor, normally insert onto the arms to facilitate shoulder movement, right? By locking the arms and fixing the shoulder girdle in place on the table, the patient reverses the muscle action. The arms become the rigid anchor, allowing those chest muscles to pull entirely on the rib cage, maximizing thoracic expansion.
It is just an instinctual attempt to gain mechanical advantage.
Exactly.
The other instinctual adaptation we see, particularly in emphysematous COPD, is pursed lip breathing.
Ah, this is fascinating fluid dynamics.
The patient inhales and then exhales very slowly through tightly restricted pursed lips. Now, to a layperson, that looks totally counterintuitive. If you're struggling to breathe, why create a bottleneck at your mouth that makes it harder to push the air out?
To understand pursed lip breathing, we really have to look at the microanatomy of emphysema. Emphysema involves the enzymatic destruction of the alveolar walls, and crucially, the destruction of the elastic tissue networks that normally tether the small airways open.
So that radial traction is just gone.
Yes. Normally, that traction keeps the bronchioles patent, or open, during exhalation. In emphysema, when the patient exhales, the positive intrathoracic pressure inside the chest physically crushes these floppy, unsupported small airways shut.
The equal pressure point shifts distally, collapsing the bronchioles before the air can even escape.
Right. It's dynamic hyperinflation. The air becomes totally trapped. So by pursing their lips, the patient creates a high-resistance bottleneck right at the oral cavity.
Okay.
This physically impedes the outflow of air, which generates a backward-traveling wave of positive pressure throughout the entire tracheobronchial tree.
Wait, so they're creating autologous positive end expiratory pressure?
Exactly. Auto-PEEP. That back pressure acts as an internal pneumatic stent. It forcefully props open those floppy small airways, shifting that equal pressure point back proximally to the cartilaginous, non-collapsible airways, allowing the trapped alveolar air to finally empty.
That is incredible. It is just a subconscious manipulation of fluid dynamics.
It is the body acting as its own CPAP machine.
Mind-blowing. Okay, moving away from the chest mechanics, the peripheral extremities offer massive diagnostic clues from the end of the bed. Let's examine cyanosis. We really have to separate peripheral cyanosis from central cyanosis.
This is a vital distinction.
Because peripheral cyanosis, blue fingertips or toes, that can simply be the result of a cold environment or a Raynaud's phenomenon or just low cardiac output states slowing down the peripheral transit time.
Right, the tissue just extracts more oxygen because the blood is moving so slowly, leading to local deoxygenation. It doesn't mean the lungs are failing.
But central cyanosis is the critical respiratory finding. You assess this by looking at the highly vascularized mucous membranes, specifically the lips and the ventral surface of the tongue.
If the tissue beneath the tongue is blue, it indicates a profound systemic failure of arterial oxygenation. Biochemically, cyanosis becomes clinically visible when the absolute concentration of circulating deoxyhemoglobin reaches roughly 5 grams per deciliter.
Which means central cyanosis is a very late, terrifying sign.
It is. It generally correlates with an arterial oxygen saturation dropping below 80%.
Okay, another vital sign in the extremities is the tremor. The classic maneuver here is asking the patient to extend their arms, spread their fingers, and aggressively dorsiflex their wrists, right? Like they're stopping traffic.
Yes, and then you just observe the hands for several seconds. You are watching for asterixis, which is often called a flapping tremor.
What exactly does that look like?
The wrists will suddenly lose motor tone, dropping forward, and then immediately jerk back into the dorsiflex position. It creates this coarse, arrhythmic, flapping motion.
I want to break down the neurology of this because it isn't actually a tremor in the classical sense like you'd see in Parkinson's, right? It's a negative myoclonus.
That is the correct terminology, yes. A true tremor involves oscillating, rhythmic contractions of antagonistic muscles. Asterixis is characterized by brief, sudden lapses of sustained posture.
And in the context of respiratory disease, what does that mean?
It is the absolute hallmark of severe hypercapnia, massive carbon dioxide retention. As the lungs fail to ventilate, arterial CO2 levels skyrocket. Carbon dioxide rapidly crosses the blood-brain barrier, altering the pH of the cerebrospinal fluid and directly disrupting the glutamatergic neurotransmission in the reticular activating system and the diencephalon.
So the hypercapnic encephalopathy essentially poisons the brain's ability to maintain a continuous efferent motor signal.
Exactly. The brain momentarily forgets to hold the wrist up, the hand drops, the reflex arc catches it, and it jerks back up. Seeing asterixis in a COPD patient means they are slipping into CO2 narcosis and are at imminent risk of complete ventilatory failure.
Wow. Okay, now let us address one of the most pervasive, stubbornly persistent myths on the medical wards regarding the hands. Finger clubbing.
Oh, this is a massive one.
If you ask 10 medical students what causes clubbing, 9 of them will confidently tell you chronic hypoxia. They always picture the classic COPD patient with a barrel chest, pursed lips, and bulbous clubbed fingers.
It is taught incorrectly at so many levels. We really must be definitive here for the listeners. Chronic hypoxia in isolation does not cause clubbing.
Period.
Emphysema does not cause clubbing. Chronic bronchitis does not cause clubbing. If you observe a patient with a known 20-year history of COPD who presents with new onset clubbing, you do not attribute it to their underlying lung disease.
What do?
You must immediately initiate a workup for a newly developed bronchogenic carcinoma.
Okay, let's dissect the physical presentation first, and then we'll get into the pathophysiology. Normal fingers have a specific geometry at the nail bed.
Right, we look at the Lovibond angle, which is the angle formed between the proximal nail fold and the nail plate itself. In a healthy individual, this angle is less than 160 degrees. It dips downward slightly.
And there's a test for that, right?
Yes.
Yeah.
If you have the patient place the dorsal surfaces of their opposing index fingers together, matching the distal interphalangeal joints, you should see a distinct diamond-shaped window of light between the bases of the nail beds.
That's Shamroth's window.
Correct. But in clubbing, there is a massive proliferation of fibrovascular tissue and interstitial edema in the connective tissue underlying the nail bed. It completely swells up, pushing the proximal nail plate upward.
So the Lovibond angle just flattens out to 180 degrees or even becomes convex.
Yes. The nail bed feels spongy upon palpation, and when the patient attempts Shamroth's window test, that diamond of light is completely obliterated. The swollen distal phalanges just sit perfectly flush against each other.
So if it isn't hypoxia, what is the actual biological driver causing this fibrovascular proliferation?
The prevailing pathophysiological model involves megakaryocytes.
Platelet precursors.
Exactly. Normally, megakaryocytes are produced in the bone marrow and travel through the venous system to the lungs. The extensive pulmonary capillary bed acts as a physical sieve, literally fragmenting these massive megakaryocytes into smaller, normal platelets.
But in certain diseases, that pulmonary capillary sieve is somehow bypassed or destroyed.
Right. In conditions involving right-to-left cardiac shunts or massive pulmonary fibrosis, or, crucially, in the highly abnormal vasculature surrounding a lung tumor, whole megakaryocytes manage to bypass the pulmonary capillary fragmentation process.
So they enter the systemic arterial circulation hole.
Yes. They travel to the distal capillary beds of the fingertips, where they become physically lodged because of their large size. Once they are trapped, they release massive localized concentrations of platelet-derived growth factor, or PDGF, and vascular endothelial growth factor, VEGF.
Oh, wow. So those growth factors trigger intense, localized angiogenesis and fibrovascular proliferation, physically expanding the fingertip.
Exactly. It is a mechanical and hormonal cascade. It points aggressively toward intrathoracic malignancy, particularly non-small cell lung cancers. It points to chronic suppurative infections that physically destroy the lung architecture, such as severe bronchiectasis, cystic fibrosis, or an empyema. And it points to fibrotic interstitial lung diseases like idiopathic pulmonary fibrosis.
So erasing the hypoxia myth from your clinical reasoning is paramount. That distinction fundamentally alters how you triage that patient on the ward.
It absolutely does.
Okay, we have completed the visual inspection. Section 3. Hands-on. We move to the tactile phase. Palpation. We are utilizing the mechanoreceptors in our hands to interrogate the density and pressure dynamics of the organs beneath the ribs. And the gateway to assessing intrathoracic pressure is the trachea.
Now, palpating the trachea is quite uncomfortable for the patient, so it must be done with purposeful gentleness. You place the tip of your index finger into the suprasternal notch, assessing the spatial relationship between the cartilaginous rings of the trachea and the medial borders of the sternal cleidomastoid muscles on both sides.
You are basically just confirming that the trachea sits directly in the midline.
Yes.
You are also checking the cricosternal distance, right? Placing your fingers between the cricoid cartilage and the suprasternal notch. Normal is usually 3 to 4 finger breadths.
And if it's drastically shortened, it suggests the lungs are hyperinflated, literally pushing the diaphragm down and functionally pulling the larynx closer to the sternum. But you're right, the primary focus here is deviation. A trachea is shifted clearly to the left or right.
Tracheal deviation is a macroscopic indicator of severe pressure or volume differentials between the two hemithoraces, because the mediastinum, which contains the trachea, is basically suspended between the two lungs.
Right. So if pathology alters the equilibrium, the mediastinum will shift. It can be pushed away from the pathology, or it can be pulled toward it.
Okay, a push implies a massive buildup of abnormal volume or pressure. Like what?
The most critical, life-threatening example is a tension pneumothorax. A one-way valve leak develops in the pleura. Air enters the pleural space during inspiration, but cannot escape during expiration.
So the intrapleural pressure just skyrockets.
Yes, totally collapsing the ipsilateral lung and then physically shoving the entire mediastinal compartment, including the trachea and the heart, toward the contralateral healthy side.
And that compresses the superior vena cava, obliterating venous return, which causes rapid cardiovascular collapse.
Exactly. A massive pleural effusion accumulating liters of fluid will exert a similar, though usually less acute, pushing effect.
Conversely, what creates a pull?
A pull implies a massive loss of lung volume. If a patient develops a large mucus plug or a central endobronchial tumor that completely occludes a main stem bronchus, the air trap distal to that obstruction is gradually resorbed into the bloodstream.
So the affected lobe, or even the entire lung, collapses upon itself.
Yes, a condition called atelectasis. This creates a powerful negative pressure vacuum within that hemithorax, which actively pulls the flexible mediastinum and the trachea toward the side of the collapsed, diseased lung. Severe asymmetrical pulmonary fibrosis can also exert a physical traction, pulling the trachea toward the scarred, shrinking tissue.
So, by simply feeling the windpipe, you are determining if the chest cavity is acting as a pressure cooker or a vacuum.
It's an incredible triage tool.
Next, we palpate the chest wall directly to assess expansion. And the technique here requires precise hand placement.
You position yourself behind the patient. You place your hands firmly on the lower posterior chest wall, hooking your thumbs just under the inferior margins of the 10th ribs, tracking parallel to the rib cage.
Okay.
You slide your hands medially toward the spine just enough to gather a loose vertical fold of skin between your thumbs. You then instruct the patient to take a maximal deep inhalation.
And you are watching the divergence of your thumbs as the rib cage swings upward and outward. In a healthy adult, those thumbs should pull apart symmetrically by about 3 to 5 centimeters.
But the absolute numerical distance is secondary. The paramount observation here is symmetry. The chest wall should expand like a bucket handle swinging upward.
So if the left thumb diverges beautifully, but the right thumb remains relatively static,
you have immediately localized a unilateral pathology. A delayed or diminished expansion on one side points to an underlying issue physically restricting that lung.
like a massive localized consolidation or a large pneumothorax preventing lung inflation.
Exactly. Or a thick pleural effusion splinting the lung. Even severe localized musculoskeletal pain from a rib fracture can cause the patient to involuntarily guard and suppress inhalation on that side.
After assessing expansion, we transition to a really interesting acoustic tactile maneuver, tactile fremitus. This is the assessment of vocal vibrations transmitted to the chest wall.
Yes, this involves the classic 99 test.
The technique requires using the ulnar border of your hand, the bony edge along the pinky side, or the base of the fingers. Why that part of the hand?
Because those rigid osseous structures are highly sensitive to detecting low-frequency mechanical vibrations. You press your hands firmly against the chest wall, following a rigid ladder pattern comparing left to right, moving down level by level, while the patient repeatedly vocalizes a resonant phrase.
And the phrase 99 is traditionally used because the long vowel sounds generate a strong, low-frequency fundamental pitch from the vocal cords.
Correct. As the patient speaks, you feel a buzzing, purring sensation against your hands, and the diagnostic power of tactile fremitus rests entirely on the physical laws of sound conduction through different states of matter.
Let's break down that physics because it's so cool. Sound waves propagate by transferring kinetic energy from one molecule to the next. Therefore, sound travels fastest and with the least attenuation through dense, solid, uniform mediums where the molecules are tightly packed together.
Exactly. It travels much less efficiently through disorganized liquids, and it travels terribly through gases where the molecules are widely dispersed and absorb the acoustic energy. I like to use a structural analogy here.
Oh, the train tracks.
Yes. Think of placing your ear against a continuous steel train track. The solid steel is a highly uniform, dense medium. It will conduct the low-frequency vibration of an approaching train from miles away with perfect clarity. You will feel it vibrating long before you hear the train through the air.
Right.
However, if there is a gap in that track, if a section of steel is missing and replaced by a pool of water or empty air, the acoustic coupling is broken. The sound waves hit the less dense medium, the energy diffuses, and the vibration dies instantly.
And that exact physical principle dictates tactile fremitus in the alveoli. Because healthy lung tissue is essentially a complex biological sponge. It is a matrix of thin tissue completely filled with air.
Yes, and because it is predominantly air, it acts as a massive acoustic dampener. It filters out most of the low-frequency vibration, which is why normal fremitus feels relatively faint to the touch.
But consider what happens in a severe lobar pneumonia. The alveolar sacs become completely engorged and packed solid with inflammatory exudate white blood cells, fibrin red blood cells, and fluid.
The spongy, air-filled lung is transformed into a dense, solid mass of tissue, a process we literally call consolidation.
So the lung becomes the solid steel train track.
Precisely. That solid column of exudate provides an uninterrupted, highly dense acoustic pathway straight from the main stem bronchi to the parietal pleura. The low-frequency vibrations of the vocal cords are transmitted with brutal efficiency.
So when you place your hand over a lobar consolidation and the patient says 99, you will feel a dramatic, localized increase in tactile fremitus. The buzzing will be significantly stronger than on the healthy side.
Increased fremitus equals solid tissue. It is a highly specific marker for consolidation.
Now, what causes the opposite? What causes decreased fremitus?
Decreased fremitus occurs when a less dense, non-conducting medium is interposed between the vibrating lung and your hand. If a patient develops a pleural effusion, a massive lake of fluid accumulates in the pleural space, physically separating the lung from the chest wall.
And liquid is a poor conductor of these specific low frequencies compared to solid tissue.
Right. The fluid absorbs and diffuses the acoustic energy.
The train track is submerged in water.
Exactly. The same principle applies to a pneumothorax, where a layer of free air separates the lung from the chest wall. Air is the ultimate acoustic insulator.
So in both cases, pleural fluid or pleural air, the transmission of vibration is blocked, resulting in a distinct decrease or complete absence of tactile fremitus over that affected area.
It's a beautifully binary physical sign. Increased means solid. Decreased means fluid or free air.
That acoustic physics perfectly sets the stage for our next section. Section 4, the art of tapping. We transition from feeling vibrations generated by the patient's vocal cords to generating our own mechanical vibrations. We move to percussion.
Percussion is arguably the most elegant, historically rich component of the physical examination.
I love the history of this. It was formalized by the Austrian physician Leopold Aumberger back in 1761.
Yes. Aumberger's father was an innkeeper and wine merchant. As a child, Leopold watched his father evaluate these massive, opaque wooden wine casks in the cellar.
By sharply tapping his knuckles against the staves of the barrel and listening to the resulting acoustic resonance, his father could accurately pinpoint the exact fluid level of the wine inside.
And Aumberger realized that the human thorax is structurally identical to those wine casks. It is a rigid, hollow barrel containing varying proportions of air, liquid, and solid tissue.
He applied that exact percussive technique to the chest wall, mapping the transition from the air-filled lungs to the solid liver, or a fluid-filled effusion. It is a brilliant example of translational observation.
But producing a clinically useful percussive note requires absolute biomechanical precision. I see residents struggle with this constantly.
Oh yeah, they tap the chest and it just sounds like a muffled, dull thud everywhere. What are the mechanical pitfalls there?
The most common error is acting as your own acoustic dampener. So your non-dominant hand acts as the pleximeter, the base plate. You must place only the distal interphalangeal joint of your middle finger firmly against the patient's skin, aligned perfectly parallel to the ribs within the intercostal space.
Only the one joint.
Yes. The critical step is that the rest of your fingers and your entire palm must be elevated and completely off the chest wall. If your whole hand rests flat against the skin, your flesh will instantly absorb the vibration, killing the sound wave before it can even propagate into the thorax.
Okay, so only one knuckle touches the patient. Everything else is airborne. And what about the striking hand?
Your dominant hand provides the plexor. You use the rigid tip of your middle finger to strike the middle phalanx of your pleximeter finger. But the kinetic energy must be generated entirely by a rapid, fluid flick of the wrist.
It is not an elbow or shoulder movement.
Not at all. The strike must be sharp, vertical, and instantly recoiling, like the strike of a piano hammer or a woodpecker. If you leave your striking finger resting on the pleximeter for even a fraction of a second after impact, you will dampen the reverberation you just created.
It really requires practice to get that clean, snapping wrist motion. As an aside, if a resident has very small hands or is examining a particularly muscular or obese patient where generating sufficient acoustic force is difficult, there is a recognized cheat.
Ah, yes. You can use the heavy rubber head of a neurological reflex hammer to strike your pleximeter finger.
It provides immense, consistent kinetic energy and produces a very loud, clear diagnostic note.
It is unconventional but highly effective in difficult anatomical scenarios. Regardless of how you strike, you are interrogating the tissue roughly 5 to 7 centimeters deep to the chest wall, and you are categorizing the resulting echo into one of 4 distinct sound profiles.
Let's define that acoustic vocabulary. The baseline note is resonance.
Resonance is the physiological standard. It is a loud, low-pitched, long-lasting, hollow sound. It is the acoustic signature of healthy, spongy lung parenchyma that is predominantly filled with air but retains enough tissue matrix to prevent the sound from booming uncontrollably.
If the air is replaced by something denser, the sound changes to dullness.
Right. Dullness is a highly attenuated sound. It is short in duration, flat, and medium to high pitched. It lacks any significant echo. It sounds exactly like percussing over a dense, solid muscle like your own quadriceps.
Anatomically, you will hear physiological dullness when you percuss downward over the right midclavicular line and transition from the lung to the solid mass of the liver.
Pathologically, though, hearing dullness over what should be resonant lung fields indicates that the air-filled alveoli have been replaced by a solid medium, such as a dense lobar pneumonia, a large peripheral tumor, or a pleural effusion.
In fact, a massive pleural effusion acts as such a profound acoustic barrier that the resulting percussive note is classically described as stony dull.
It literally feels like tapping on a brick wall.
On the opposite end of the acoustic spectrum, if there is too much air, you get hyperresonance.
Hyperresonance is a very loud, booming, lower-pitched sound that reverberates longer than normal resonance. It indicates a pathological increase in trapped air within the thoracic cavity, with a corresponding decrease in solid tissue density.
So if you hear hyperresonance bilaterally across all lung fields, you are likely examining a patient with severe COPD or emphysema, where the lungs are chronically hyperinflated and the alveolar septa are destroyed.
Exactly. But if you hear unilateral hyperresonance, a booming sound on one side and normal resonance on the other, it is a massive red flag for a large pneumothorax. Free air under pressure in the pleural space acts exactly like an overinflated drum.
The final sound is tympany.
Tympany is a distinct, high-pitched, musical, drum-like note. You generally do not hear true tympany over the lung fields. It is generated when percussing over a large, hollow, enclosed viscus filled with gas.
The classic anatomical location being Traub's space on the anterior left lower chest, which overlies the gastric bubble of the stomach.
Right. Knowing these transitions allows you to dynamically map the internal organs, which brings us to measuring diaphragmatic excursion. This is a brilliant bedside test to quantify the functional mobility of the respiratory pump.
Right. You perform this on the posterior thorax. You instruct the patient to exhale completely and hold their breath. The diaphragm ascends to its highest resting position.
You then percuss downward along the mid-scapular line, starting from the resonant lung fields. The exact millimeter where the percussive note abruptly changes from hollow resonance to the flat dullness of the subdiaphragmatic organs, you make a mark. This represents the fully exhaled diaphragmatic border.
Then you instruct the patient to take a maximal deep breath in and hold it.
The lungs fully inflate, forcefully pushing the diaphragm inferiorly. You percuss downward again from your initial mark until you hit the new transition point of dullness, and you make a second mark.
And you measure the vertical distance between those two lines. In a healthy, functioning pulmonary system, the diaphragm should descend symmetrically by 3 to 5 centimeters.
If the excursion is severely blunted, say less than a centimeter, it indicates significant mechanical restriction.
This could be due to severe hyperinflation from emphysema, where the diaphragm is already chronically flattened, right? Or bilateral diaphragmatic paralysis from a phrenic nerve injury, or even a massive abscess in the abdomen, physically preventing the diaphragm from descending.
Yes. And the cardinal rule of percussion, which mirrors palpation perfectly, is the rigid adherence to a comparative ladder pattern.
You have to go side to side.
It is neurologically imperative. The human auditory cortex is relatively poor at recalling absolute pitch over time, but it is exquisitely sensitive to detecting immediate relative differences in pitch and tone. Respiratory pathology is rarely perfectly symmetrical.
By percussing the left posterior base and then immediately crossing over to percuss the exact corresponding anatomical location on the right posterior base, a subtle unilateral zone of dullness will instantly jump out at you.
If you percuss an entire hemothorax before moving to the other, you just lose that immediate comparative advantage.
Okay, we have mapped the anatomy, visually assessed the mechanics, palpated the pressure dynamics, and percussed the densities. We now arrive at Section 5, the centerpiece of the exam, the masterclass in auscultation.
Placing the stethoscope on the chest wall is not merely an exercise in listening for vague noises. It is the meticulous categorization of fluid dynamics and acoustic filtration.
Proper auscultation requires preparation. You utilize the diaphragm of your stethoscope as it is optimized for the higher frequency sounds generated by airflow. You follow the established comparative ladder pattern.
And crucially, you must instruct the patient to breathe deeply in and out through an open mouth.
Not the nose.
Never the nose. Nasal breathing generates massive turbulent airflow in the narrow nasopharynx, which creates loud, high-frequency noise that is transmitted straight down the trachea and across the chest wall, completely obscuring subtle parenchymal lung sounds.
We start by evaluating the underlying baseline breath sounds. We have to differentiate normal laminar flow from pathological turbulent transmission. Let's begin with normal vesicular breath sounds.
Vesicular sounds are the healthy, baseline acoustic profile heard over the vast majority of the peripheral lung fields. They are described as soft, low-pitched, and feathery, often compared to the gentle rustling of leaves in a breeze.
And the defining characteristic of a vesicular sound is its specific timing. The inspiratory phase is prominently louder and significantly longer than the expiratory phase.
Yes. You hear the continuous rush of air filling the alveoli during the entire inhalation, but the sound of exhalation trails off and becomes inaudible about a third of the way through the expiratory phase.
Why does the sound disappear during expiration?
It relates to the physics of airflow and acoustic filtration. During inspiration, air is accelerating and dividing through miles of progressively narrowing branching airways, generating widespread turbulence and sound.
But during exhalation?
During passive exhalation, the airflow is decelerating and merging into larger airways, which generates significantly less acoustic energy. Furthermore, the millions of microscopic air-filled alveoli act as a highly effective low-pass acoustic filter.
So they heavily attenuate the higher frequency sounds of exhalation before they could even reach the stethoscope on the periphery.
Exactly.
Now contrast that soft, filtered vesicular sound with bronchial breath sounds.
Bronchial sounds represent the raw, unfiltered acoustic energy of the central airways. They are harsh, hollow, tubular, and distinctly higher pitched. They sound like wind violently blowing through a hollow steel pipe.
The timing profile is the exact inverse of vesicular sounds, right? The expiratory phase is equal to, or even longer and louder than, the inspiratory phase.
Yes. And critically, there is a distinct silent pause, a temporal gap between inspiration and expiration.
But hearing bronchial sounds is entirely context-dependent. It isn't inherently pathological.
Correct. If you place your stethoscope directly over the trachea in the anterior neck or over the manubrium, you will hear loud, perfectly normal bronchial breath sounds. You're listening directly to the massive, high-velocity, turbulent airflow crashing through the large central airway.
But the danger, the massive klaxon-ringing red flag, is when you hear those harsh, tubular bronchial sounds out in the peripheral lung fields at the bases or in the axilla, where you should only be hearing soft vesicular rustling.
Hearing peripheral bronchial breathing is one of the most pathological findings in the respiratory exam. Think back to our acoustic filtration principle. The air-filled alveoli normally filter out the harsh, high-frequency expiratory sounds of the central airways. If you hear bronchial breathing at the base of the lung, it means that the biological acoustic filter has been completely destroyed. The spongy, air-filled parenchyma has been replaced by a dense, solid, uniform medium, almost universally a lobar consolidation filled with fluid and inflammatory cells.
That dense consolidation acts as a perfect, solid-state acoustic pipe. It captures the harsh, turbulent noise from the central bronchi and transmits it flawlessly without any high-frequency filtration straight to the chest wall.
If you hear loud bronchial breath sounds in the right lower lobe, you have functionally diagnosed a dense consolidation. It is pneumonia until proven otherwise.
Once we identify the baseline breath sounds, we actively listen for adventitious sounds, the superimposed abnormal added noises. The clinical terminology here is vital. Let's start with crackles, which older attendings may still refer to by the French term rales.
Crackles are discontinuous, non-musical, highly brief bursts of acoustic energy. They sound like a series of microscopic explosions or pops. To derive diagnostic meaning, we must divide them into fine crackles and coarse crackles because they represent entirely different pathophysiological mechanisms.
Let's examine fine crackles first. The classic description is that they sound exactly like slowly tearing apart a strip of Velcro near your ear. They are high-pitched, very dry, and typically occur late in the inspiratory phase. What is physically happening to create that Velcro sound?
Fine crackles are generated deep within the terminal bronchioles and the alveoli. In restrictive interstitial lung diseases, such as idiopathic pulmonary fibrosis, asbestosis, or severe connective tissue disease, the delicate alveolar walls become thickened, scarred, and highly non-compliant.
They get stiff.
Very stiff. During exhalation, these stiffened, damaged alveoli collapse shut. During the subsequent inhalation, as the negative intrathoracic pressure builds, these collapsed units suddenly and violently pop open under the tension.
That explosive equalization of pressure generates the sharp, high-pitched crackle. It is a sign of structural parenchymal disease.
Exactly. Contrast that with coarse crackles. These are louder, much lower pitched, and longer in duration. They sound wet, like blowing bubbles through a straw into a thick milkshake, or the sound of water boiling.
Coarse crackles originate in the larger bronchi and the macroscopic airways. They are generated when inhaled air is forced to bubble and churn through pools of accumulated fluid, thick, purulent mucus, or pulmonary edema fluid resting in the airways.
You will hear coarse crackles prominently during the early stages of congestive heart failure, as hydrostatic pressure forces transudative fluid into the alveoli, or in the exudative phase of a severe pneumonia, or in patients with massive mucus hypersecretion like severe bronchiectasis.
And there is a brilliant, immediate bedside test to differentiate the severity of these crackles. If you hear coarse crackles, pull your stethoscope away and ask the patient to execute a strong, forceful, deep cough. Then, immediately auscultate the exact same area again.
The cough test is essential. If the patient coughs and the coarse crackles completely vanish or significantly change their acoustic character, it confirms that the sound was merely generated by loose, mobile secretions rattling in the main airways, which the high-velocity cough successfully expectorated.
It is a transient airway issue, not a deep parenchymal disease.
Exactly. However, if the patient coughs and the fine Velcro-like crackles remain completely unchanged, locked in the exact same phase of inspiration, it confirms irreversible structural fibrosis deep in the alveolar bed. A cough cannot clear a scar.
The next category of adventitious sounds involves continuous musical acoustics. The wheeze.
A wheeze is a continuous, high-pitched harmonic whistling sound. It is governed entirely by Bernoulli's principle and the fluid dynamics of turbulent flow. Wheezes are the acoustic signature of air being forcefully squeezed through narrowed, constricted, or inflamed airways.
We classically associate them with bronchospastic diseases like asthma or chronic obstructive conditions like COPD.
But the temporal relationship of the wheeze to the respiratory cycle provides a critical grading of severity.
How so?
Due to the natural tethering of the lung parenchyma, intrathoracic airways naturally dilate slightly during the negative pressure of inspiration, and they naturally constrict slightly during the positive pressure of expiration.
Okay, so they open a bit on the way in and close a bit on the way out.
Exactly. Therefore, in mild to moderate bronchospasm, the airway is still wide enough during inhalation to allow silent airflow. It only reaches a critical degree of narrowing during exhalation. This generates an expiratory-only wheeze.
But if the asthma attack progresses, the airway wall edema and smooth muscle constriction becomes so severe that the lumen remains critically narrowed even during the natural dilation of inhalation.
If you auscultate a patient and hear a loud wheeze during both expiration and inspiration, you are dealing with a severe, highly advanced degree of airway compromise. The airflow is turbulent throughout the entire respiratory cycle.
Which leads to a terrifying clinical paradox that often catches junior clinicians off guard: the concept of the silent chest. You walk into the room of a patient suffering a massive status asthmaticus exacerbation. They're tripoding, cyanotic, utilizing every accessory muscle, visibly gasping for survival.
You place your stethoscope on their chest, expecting to hear a symphony of loud, screaming wheezes, and instead, you hear absolute terrifying silence. No wheeze, no breath sounds, nothing.
Do not mistake acoustic silence for clinical improvement.
Never. Generating a wheeze requires at least a baseline threshold of kinetic airflow to vibrate the narrowed bronchial walls. If the bronchospasm, mucosal edema, and mucus plugging become so absolute, so profoundly tight that virtually zero air is moving in or out of the alveoli, the kinetic energy drops below the threshold required to produce sound.
The wheeze just vanishes. A silent chest in a patient exhibiting maximal mechanical effort is the harbinger of imminent respiratory arrest. They are completely locked up. They require immediate aggressive resuscitation, likely including mechanical ventilation, to save their life.
Silence is the loudest alarm in respiratory medicine.
The final adventitious sound is localized and mechanical. The pleural friction rub.
A pleural friction rub is a harsh, rough, grating, non-musical sound. It is distinctly superficial, sounding as if it is occurring directly beneath the diaphragm of your stethoscope.
The classic acoustic comparisons are the sound of two pieces of stiff, dry leather being forcefully rubbed together, or the crunching sound of walking heavily on fresh, hard-packed snow. What drives this mechanical crunching?
Under healthy conditions, the visceral pleura tightly enveloping the lung parenchyma and the parietal pleura lining the interior of the rib cage slide smoothly past one another during every breath, perfectly lubricated by a few milliliters of serous pleural fluid.
But if those pleural membranes become inflamed, a condition known as pleuritis or pleurisy, they become engorged, hyperemic, and roughened by deposits of sticky fibrin.
This inflammation can be triggered by a peripheral pneumonia extending to the pleural surface, a pulmonary infarction from a pulmonary embolism, or an autoimmune vasculitis. Regardless of the cause, the lubrication is lost.
So as the lung expands and contracts, these two roughened, sandpaper-like surfaces physically scrape and catch against each other.
Because the sliding motion occurs continuously, you will typically hear the crunching friction rub prominently during both inspiration and expiration.
And there is a fascinating mechanical evolution here. If that localized pleuritic inflammation continues to worsen, the capillary beds leak and a large pleural effusion begins to accumulate.
Because the fluid volume increases, it physically wedges between the visceral and parietal pleura, floating them apart. The roughened surfaces can no longer touch. Consequently, the harsh friction rub will abruptly disappear from your exam, replaced by the dullness and decreased breath sounds of the new effusion.
The pain often paradoxically improves, just as the underlying disease actually worsens.
It is a tricky clinical presentation.
The final frontier of the Auscultatory Master Class involves assessing vocal resonance. We return to analyzing how the patient's voice travels through the lung, but this time, instead of feeling it with our hands like tactile fremitus, we listen to it with the stethoscope.
Vocal resonance is the definitive acoustic test for consolidation. Under normal conditions, if you place your stethoscope over the peripheral lung bases and ask the patient to speak in a normal conversational volume, the sound you hear will be heavily muffled, diffuse, and completely unintelligible.
You can hear the low-frequency hum of their voice, but the spongy, air-filled alveoli act as a powerful acoustic scatterer, destroying the high-frequency harmonics required to distinguish consonants and syllables. You cannot understand what they are saying.
But if pathology alters that density, the transmission physics flip entirely. Let's break down the three distinct pathological signs of abnormal vocal resonance. The first is bronchophony.
You instruct the patient to repeatedly say 99 in a normal speaking voice.
If you place your stethoscope over a dense lobar consolidation, the solid massive exudate completely bypasses the normal acoustic scattering. The sound waves travel through a uniform solid medium straight to the chest wall.
You will hear the words 99 loudly, distinctly, and with disturbing clarity, as if the patient is speaking directly into the tubing of your stethoscope. That enhanced transmission is bronchophony.
The second sign takes this principle to the absolute extreme: whispered pectoriloquy. It is one of the most highly sensitive physical signs for detecting a solid consolidation.
You instruct the patient to exhale completely and then softly whisper the numbers 1, 2, 3. Now, the physics of a whisper are totally different from normal speech. A whisper involves forcing air across partially adducted vocal cords without vibrating them. It generates a very low amplitude, entirely high-frequency acoustic signal.
Exactly. And because it is purely high frequency, normal air-filled spongy lung tissue will instantly and completely absorb the sound. If you listen over healthy lung while a patient whispers, you will hear absolute dead silence. Not a single sound will penetrate to the chest wall.
But a dense mass of inflammatory consolidation acts as a perfect high-fidelity amplifier for high frequencies.
It conducts the whisper flawlessly. If you place your stethoscope over that pneumonic consolidation and the patient whispers, you will hear 1, 2, 3 blasting through your earpieces with crystal clear articulation. It is an unnerving acoustic phenomenon.
René Laennec, the French physician who invented the stethoscope in 1816, was the first to document this. He coined the term pectoriloquy, derived from Latin, which literally translates to chest speaking. The consolidated lung is bypassing the mouth and speaking directly to the physician.
Laennec's other massive contribution to the acoustic vocabulary is the third sign of abnormal resonance, egophony. It is derived from the Greek root word for goat. Laennec described the sound as resembling the harsh, nasal bleating of a goat.
To elicit this sign, you ask the patient to continuously vocalize a long, steady, high-pitched E sound. Over healthy lung tissue, the stethoscope simply transmits a muffled, distant, continuous E sound.
But when that sound wave encounters a dense consolidation, or, crucially, when it passes through the thin upper fluid meniscus of a pleural effusion, the acoustic physics of the abnormal medium fundamentally distort the harmonics of the vowel. The lower frequencies are absorbed, and the higher frequency nasal overtones are amplified and phase shifted.
The sound is entirely transmuted. When the patient says a clear E at the mouth, the sound that blasts out of your stethoscope is a harsh, compressed, nasal...
The classic E-to-A transition. If you are examining a patient with a high fever and a cough, and over their right lower lobe you detect a localized area of dullness to percussion, harsh bronchial breath sounds, distinct whispered pectoriloquy, and a positive E-to-A egophony change, you have achieved diagnostic certainty.
You have identified a dense lobar consolidation. You do not need to wait 2 hours for the portable chest X-ray to confirm it. You can confidently initiate targeted antibiotic therapy immediately based entirely on your mastery of acoustic physics.
Which provides the perfect transition to the final phase of this deep dive. Section 6. Translating signs to diagnoses. We have spent an hour building this massive, exhaustive toolkit.
We have covered the anatomy, the visual inspection, the tactile physics, and the Acoustic Master Class. Now, we place you on the ward. We are going to review 4 highly specific, complex clinical case studies. We will analyze the presentation, execute the physical exam, construct the differential diagnosis, and rigorously defend our clinical reasoning.
This is the practical application. This is where rote memorization ends and true clinical medicine begins.
Case study number 1, the classic consolidation. Let's evaluate Ms. Chen. Ms. Chen is a 45-year-old dispute mediator. She has a significant smoking history, documenting 2 packs a day for 20 years. She presents to the emergency department with a rapid 1-week history of a worsening, highly productive cough.
She reports expectorating thick, yellow-green, purulent sputum that is occasionally streaked with pink blood. She has a documented fever of 101.5 degrees Fahrenheit, and she reports progressive dyspnea upon exertion.
Let us systematically apply the physical exam. On general inspection, she does not exhibit central cyanosis, but she is mildly tachypneic with a resting respiratory rate of 22 breaths per minute.
Palpation reveals a distinct asymmetric increase in tactile fremitus localized over the left lower posterior thorax. Percussion over that exact area yields a flat, high-pitched note of dullness.
Auscultation over the left lower lobe reveals harsh, bronchial breath sounds, superimposed coarse crackles that do not fully clear with coughing, and a strongly positive E-to-A egophony change.
The clinical presentation is highly suggestive, but the physical exam makes it definitive. The primary diagnosis is community-acquired pneumonia, specifically a lobar consolidation likely driven by a typical bacterial pathogen such as Streptococcus pneumonia.
But in a masterclass, we must aggressively defend why it is not the other possibilities. Let's build the differential. Why isn't this simply an acute exacerbation of chronic bronchitis? She is a heavy smoker with a highly productive cough.
An acute bronchitis is fundamentally an inflammatory process restricted to the larger conducting airways, the bronchi. It is mucosal inflammation and mucus hypersecretion. Because the inflammation does not extend down into the terminal alveoli, the underlying spongy lung parenchyma remains perfectly intact and air-filled.
Therefore, an acute bronchitis will never alter the acoustic density of the lung. A patient with bronchitis will have normal resonance to percussion, normal tactile fremitus, and normal vesicular breath sounds, perhaps with some transient coarse crackles or rhonchi from the airway mucus.
Miss Chen's exam reveals dullness, increased fremitus, and egophony. These are the absolute, unarguable acoustic signatures of dense alveolar filling. The lung tissue itself is consolidated. Bronchitis is ruled out.
What about tuberculosis? She is presenting with hemoptysis, pink streak sputum, and a fever.
Tuberculosis must always be considered when hemoptysis is present, but the temporal evolution of her symptoms strongly argues against it. Primary or reactivated pulmonary tuberculosis is characteristically a chronic, insidious, indolent infection.
The classical presentation evolves over weeks to months, dominated by severe nocturnal diaphoresis, drenching night sweats, and profound, unexplained weight loss.
Furthermore, hemoptysis in TB is typically a late-stage manifestation, occurring when the caseating granulomatous infection physically erodes into a pulmonary blood vessel, often within a large apical cavity.
Miss Chen's presentation is incredibly acute. A rapid 7-day onset of high fever and purulent sputum. The pink streaking in her sputum is likely due to the intense acute microvascular inflammation and alveolar capillary leakage associated with a typical bacterial lobar pneumonia. It is rusty sputum, not a cavitary hemorrhage.
The final major mimic, malignancy. She is 45 years old with a massive 40-pack year smoking history. Lung cancer is a statistical probability, and a tumor can cause a cough and hemoptysis.
True, a bronchogenic carcinoma is a high concern in this demographic. However, an isolated primary lung tumor does not typically present with an acute 101.5-degree febrile illness and purulent yellow-green sputum. Malignancy causes insidious symptoms: chronic dry cough, weight loss, and painless hemoptysis.
Now, a massive central tumor could obstruct a main bronchus, leading to impaired clearance, and a secondary post-obstructive bacterial pneumonia developing behind the blockage. But the acute clinical driver bringing her to the hospital today is the active infectious consolidation.
So, clinical reasoning dictates a primary diagnosis of CAPP. The targeted workup is immediate. Continuous pulse oximetry, a posterior, anterior, and lateral chest X-ray to visually map the extent of the left lower lobe, infiltrate, and assess for a peripneumonic effusion.
A complete blood count with differential, looking for a prominent leukocytosis with a left shift indicating a massive neutrophil response to bacteria. A comprehensive metabolic panel to assess renal and hepatic function, which will dictate our antibiotic dosing and assess for sepsis-induced end organ damage.
And crucially, we secure a deep sputum culture and a gram stain before administering the first dose of broad-spectrum antibiotics, allowing us to eventually narrow the therapy to the specific offending organism.
That is complete, definitive clinical management derived directly from acoustic findings.
Let's move to case study number 2, the pleuritic mimic. We evaluate Harry. Harry is a 23-year-old plumber. He arrives at the emergency department in a state of sheer panic. He reports a 24-hour history of sudden, excruciatingly sharp pain located centrally and slightly to the left side of his chest.
He describes the pain as a stabbing sensation that becomes agonizingly worse whenever he attempts to take a deep breath, or, critically, whenever he tries to lie flat supine on the examination bed.
He notes that the pain is moderately alleviated if he sits upright and leans his torso forward. A review of systems reveals he suffered from a mild viral upper respiratory tract infection with rhinorrhea and a sore throat approximately 1 week ago.
This is a presentation where the history is highly dramatic, but the physical exam is the ultimate arbiter. What are the respiratory findings?
We execute the entire protocol. General inspection shows a young man in distress due to pain, taking shallow, guarded breaths to avoid the sharp catch, but he is not using accessory muscles and is not cyanotic.
Palpation reveals normal, symmetric expansion and normal fremitus. Percussion yields bilateral resonance. Auscultation reveals crystal clear, normal vesicular breath sounds in all fields. No crackles, no wheezes, no consolidation signs. The respiratory exam is completely unequivocally normal.
This is a brilliant diagnostic pivot. We have a young man who is convinced he is suffering a massive myocardial infarction because his chest pain is so severe. But the clinical triad of sharp pleuritic pain, dramatic postural relief, and a completely pristine pulmonary exam heavily directs the diagnosis away from the lungs and toward acute pericarditis, an inflammation of the pericardial sac enveloping the heart.
Let's construct the differential and tear it down. Why isn't he having a heart attack?
The character of ischemic cardiac pain is fundamentally different. The pain of a myocardial infarction is classically described as a deep, visceral, crushing heaviness or pressure, the classic elephant sitting on my chest. It often radiates to the left jaw or the medial aspect of the left arm.
Crucially, true ischemic cardiac pain is utterly unaffected by respiration or body position. Taking a deep breath does not make a heart attack hurt more. Harry's pain is pleuritic. It is sharp, stabbing, and exacerbated by the mechanical expansion of the thorax.
Okay, so pleuritic pain brings us to the lungs. A pulmonary embolism, a blood clot lodged in the pulmonary vasculature, is a life-threatening cause of sudden, sharp, pleuritic chest pain. Why isn't this a PE?
A pulmonary embolism must always be considered, but the broader clinical context doesn't fit the pattern. A significant PE usually presents with sudden, unexplained, profound dyspnea out of proportion to the chest pain. You would expect significant resting tachycardia and a drop in pulse oximetry due to the sudden VQ mismatch.
Furthermore, Harry lacks any classical risk factors for venous thromboembolism. No recent prolonged travel, no recent surgery, no history of malignancy, no unilateral leg swelling indicative of a deep vein thrombosis.
The ultimate key to Harry's diagnosis is the positional nature of the agony.
Exactly. The positional relief is the hallmark of pericardial inflammation. The pericardium is heavily innervated by the phrenic nerves. When Harry lies supine, gravity pulls the heavy mass of the heart posteriorly against the spine.
This physically stretches the inflamed anterior aspect of the pericardial sac, causing agonizing pain. When he sits upright and leans forward, gravity pulls the heart anteriorly away from the spine, relieving the mechanical tension on the inflamed sac and immediately easing the pain.
That pathognomonic positional shift, combined with the prodromal viral illness, which is the most common etiology of acute viral pericarditis, and a completely normal lung exam, solidifies the diagnosis.
You would confirm this with an EKG, looking for diffuse ST segment elevations and PR segment depressions across multiple leads, indicating widespread pericardial inflammation rather than localized ischemia. The normal lung exam proves the pain, while affected by breathing, is not originating from the pulmonary parenchyma.
Case study number 3, the systemic mimic.
Yeah.
We evaluate Mrs. Kelly. Mrs. Kelly is a 48-year-old patient who schedules an urgent clinic visit. Her chief complaint is severe, progressively worsening shortness of breath over the past month.
She states she constantly feels air hunger, unable to draw a satisfying full breath. Upon further questioning, she reports a constellation of accompanying systemic symptoms: continuous palpitations, profuse palmar diaphoresis, sweaty hands, significant irritability, severe insomnia, and an unintentional 5-pound weight loss over the last 4 weeks.
This is a complex, multidimensional presentation. A chief complaint of shortness of breath naturally focuses our attention squarely on the pulmonary system. But we must uncover the trigger. What precipitated this month-long decline?
During the social history, Mrs. Kelly breaks down and reveals that exactly 1 month ago, her husband, who is 10 years older and a former heavy smoker, was diagnosed with severe coronary artery disease and is scheduled for an impending high-risk coronary artery bypass graft surgery. She expresses profound, overwhelming terror that he will not survive the operation.
The psychosocial timeline correlates perfectly with the onset of physical symptoms. But we cannot assume a psychological etiology without rigorously ruling out organic pathology. We proceed to the physical exam.
Her vital signs show a normal blood pressure. Her heart rate is mildly tachycardic at 88 beats per minute. Her respiratory rate is completely normal, unlabored at 18 breaths per minute. Her oxygen saturation is 99% on room air.
The physical examination of her thorax inspection, palpation, percussion, and auscultation is absolutely pristine. There are no adventitious sounds, no wheezes, no signs of hyperinflation. We broaden the exam. Examining her neck, there is no palpable thyroid goiter.
Examining her face, there is no exophthalmos, no bulging of the eyes. Asking her to extend her hands reveals sweaty palms, but absolutely no fine resting tremor.
This case exemplifies the danger of anchoring bias. A patient complains of dyspnea, and the junior clinician spends an hour hunting for a non-existent lung disease. The physical exam emphatically proves her respiratory mechanics and acoustic properties are flawless. Therefore, the feeling of air hunger is a systemic manifestation, not a pulmonary one.
We must evaluate the systemic mimics. The differential focuses on generalized anxiety disorder versus thyrotoxicosis versus, again, a chronic pulmonary embolism. Let's address the PE first.
A subacute recurrent shower of small pulmonary emboli can indeed present with progressive dyspnea and persistent tachycardia as the right heart strains against increasing pulmonary vascular resistance. But again, we look at the clinical picture. She has no deep vein thrombosis risk factors.
Crucially, her oxygenation is perfect at 99%, and she lacks any pleuritic chest pain or signs of right heart failure like jugular venous distension. The clinical probability of a PE here is exceedingly low.
The more compelling organic mimic is hyperthyroidism, specifically a thyroid storm. She has a racing heart, profuse sweating, unexplained weight loss, irritability, and insomnia. Those are all classic symptoms of a hypermetabolic thyrotoxic state.
They are, and hyperthyroidism must remain high on the differential until ruled out by laboratory testing. However, the physical exam significantly lowers our clinical suspicion. While she has the hyperadrenergic symptoms of sweating and tachycardia, she entirely lacks the structural hallmarks of Graves' disease or toxic nodular goiter.
The absence of an enlarged thyroid gland, the lack of proptosis or exophthalmos, and most importantly, the complete absence of a fine, high-frequency resting motor tremor make a severe thyrotoxicosis capable of causing that degree of weight loss highly unlikely.
Which brings us to the definitive clinical diagnosis synthesized from the psychosocial history and the negative physical exam. Generalized anxiety disorder triggered by profound acute stress.
The human autonomic nervous system is a blunt instrument. The sympathetic axis, the fight-or-flight response, cannot differentiate between an immediate physical threat to survival and a profound, overwhelming emotional terror regarding a loved one. Mrs. Kelly's fear of her husband's impending surgery has locked her sympathetic nervous system into a state of chronic, relentless overdrive.
The massive, continuous release of epinephrine and norepinephrine drives the constant palpitations, the diaphoresis, the insomnia, and the elevated basal metabolic rate leading to weight loss. The feeling of shortness of breath is likely secondary to sympathetic hyperventilation and an altered central perception of respiration.
The completely normal respiratory exam confirms that her lungs are architecturally and functionally perfect. Her mind is driving the physiology. The appropriate workup here is conservative. A TSH level to definitively rule out a thyroid disorder, a baseline EKG to confirm the tachycardia is sinus and not an arrhythmia, and then immediate referral for cognitive behavioral therapy, coupled with a trial of an SSRI or a short-term anxiolytic to help downregulate her overloaded sympathetic axis.
The exam proves that treating the lungs would be treating the wrong organ system entirely.
Our final case study brings us to the absolute terrifying extreme of pulmonary medicine. Case study number 4. The severe exacerbation. We evaluate D, an 18-year-old female patient with a known history of severe, brittle asthma. She presents to the emergency department via ambulance. She was alone in her apartment at night when the attack began.
Upon arrival, you do not need to utilize a stethoscope to make a diagnosis. The wheezing is so loud and high-pitched it is audible from the doorway. She is visibly gasping, utilizing maximal accessory muscle effort. Her sternocleidomastoids are violently contracting with every breath.
She is completely unable to vocalize a single word to answer your questions. Her mother, who followed the ambulance, states she exhausted her albuterol rescue inhaler at home with zero clinical improvement.
We include this case not to debate an obscure differential diagnosis, but to highlight the climax of physiological decompensation. This is the visual and acoustic reality of status asthmaticus, a life-threatening respiratory emergency where the inflammatory bronchospasm has become entirely refractory to standard outpatient therapy.
There is no time for a prolonged percussion exam here.
No. The visual inspection alone triages her to the resuscitation day. Her absolute inability to speak, coupled with maximal accessory muscle recruitment, indicates that her functional residual capacity is exhausted and her work of breathing has reached an unsustainable metabolic limit. The audible wheezing confirms profound, diffuse, turbulent flow through critically narrowed bronchioles.
However, the greatest danger in this scenario is if that loud, screaming wheeze suddenly stops, resulting in the silent chest we discussed earlier.
This patient is experiencing dynamic hyperinflation. Air is entering the alveoli but cannot escape the severe expiratory obstruction. Her lungs are becoming increasingly hyperinflated, flattening her diaphragm and rendering it mechanically useless, forcing her to rely entirely on the rapidly fatiguing muscles of her neck.
The clinical intervention here must be immediate, aggressive, and multimodal. She requires continuous high-dose nebulized beta-agonist and anticholinergics to force bronchodilation. She requires immediate intravenous systemic corticosteroids like methylprednisolone to halt the massive inflammatory cascade driving the mucosal edema.
If she fails to improve, you escalate to intravenous magnesium sulfate to force smooth muscle relaxation, and you immediately prepare the airway equipment because respiratory muscle fatigue will inevitably lead to hypercapnic respiratory arrest, requiring mechanical intubation.
And once she is stabilized, this case highlights the paramount importance of mentorship and patient education. A young patient with brittle asthma must be equipped with a rigorous, heavily detailed self-management action plan, ensuring they recognize the early signs of decompensation and seek aggressive medical intervention long before they reach this terrifying precipice alone in the dark.
The physical exam saves her life tonight, but the clinical mentorship prevents her from returning next month.
Which brings us to the conclusion of this massive, exhaustive journey through the respiratory physical exam. Let's synthesize the enormous volume of clinical knowledge we have unpacked. We began by establishing the rigid architectural blueprint of the thorax, utilizing the angle of Louis as our central anchor and mapping the asymmetrical geometry of the lobes, specifically highlighting the treacherous, purely anterior positioning of the right middle lobe.
We moved to the visual inspection, proving that the exam begins from the doorway. We analyzed the profound physiological implications of speech patterns, the mechanical struggle of accessory muscle recruitment, and the brilliant adaptive fluid dynamics of pursed lip breathing generating auto-PEEP.
We decisively dismantled the pervasive myth linking chronic hypoxia to clubbing, properly aligning that physical sign with the VEGF-driven fibrovascular proliferation seen in malignancies and fibrotic disease. We decoded the neurological failure of the blood-brain barrier manifesting as the hypercapnic asterixis flap.
We engaged our tactile senses, understanding the pressure dynamics behind tracheal deviation, the push of the tension pneumothorax versus the pull of atelectasis. We explored the deep acoustic physics of tactile fremitus, applying the train track analogy to understand why low-frequency vibrations amplify through the dense consolidation of a pneumonia, but die instantly when hitting the acoustic insulators of a pleural effusion or a pneumothorax.
We studied the elegant historical art of percussion developed by Auenbrugger, mastering the rigid biomechanics of the pleximeter and plexor to avoid dampening our own acoustic signal. We mapped the internal densities, transitioning from the hollow resonance of healthy lung to the flat, stony dullness of fluid effusion to the booming hyperresonance of trapped air, utilizing these notes to accurately measure the functional excursion of the diaphragm.
And we mastered the acoustic landscape of the stethoscope. We differentiated the low-pass filtered, feathery sound of normal vesicular breathing from the harsh, high-frequency, unfiltered danger of peripheral bronchial breath sound signaling consolidation.
We categorized the adventitious sounds, the explosive popping of fine fibrotic crackles versus the wet bubbling of coarse airway secretions, the high-velocity turbulent whistle of the wheeze versus the terrifying warning of the silent chest, and the mechanical leathery crunch of the pleural friction rub. We listen to the consolidated lung bypass the normal acoustic filters and speak directly to us through whispered pectoriloquy and the distorted goat-like harmonics of egophony.
Finally, we applied this massive diagnostic toolkit to the chaotic reality of the clinical ward. We isolated the dense lobar consolidation in Miss Chen, relying on dullness and egophony over an X-ray. We successfully identified the positional pleuritic agony of Harry's pericarditis by trusting a pristine lung exam. We recognized the profound systemic sympathetic overdrive mimicking dyspnea in Mrs. Kelly's anxiety presentation, and we respected the visual terror of impending respiratory failure in an acute status asthmaticus exacerbation.
I want to leave our primary audience, the resident, the intern, the junior clinician, standing in the hospital corridor at 3 a.m. with a final provocative thought regarding the future of your profession.
What is the question they need to ask themselves?
Think about the immense historical timeline of the skills we just dissected. Leopold Auenbrugger watched his father tap wooden wine casks in 1761 to invent clinical percussion. René Laennec rolled up a tube of paper in 1816 to invent the stethoscope simply because he was too embarrassed to place his ear directly on a female patient's chest. These techniques are rooted in the acoustic physics of the 18th and 19th centuries, and yet here we are in the 21st century teaching them with the exact same reverence and demanding the exact same mastery.
It is a profound juxtaposition of eras.
But we are accelerating rapidly into an entirely new paradigm. We are moving to the era of the handheld, point-of-care pocket ultrasound that can instantly visualize a pleural effusion or beelines of pulmonary edema at the bedside. We are entering the era of artificial intelligence diagnostic algorithms that can ingest and interpret a high-resolution chest CT scan in 2 seconds, identifying a 3 mm right middle lobe consolidation that you could never possibly hear from the axilla.
The technological advancement is undeniable and unstoppable.
So the fundamental question becomes, will these acoustic, tactile, 18th century physical skills eventually become a lost art? Will they be relegated to medical history books, viewed as quaint relics of a time before we could simply look inside the body with a screen? Or is there something irreplaceable in the physical touch? Will the act of physically laying your hands on a frightened patient, of feeling the mechanical struggle of their breath, of listening deeply to the muddy acoustic waters of their chest, will that remain the unbreakable essential foundation of the human doctor-patient connection?
It is the defining existential question for the next generation of diagnosticians.
Next time you place your stethoscope on a patient's chest, ask yourself, what are you really listening for? Are you just listening for a noise, or are you listening for the humanity?